Heart failure basically means inability of the heart to maintain tissue perfusion. Okay, it can be due to systolic heart failure, that is inability to pump the blood. It can be due to diastolic heart failure because of increased compliance to the ventricular filling. Now, first of all, we will discuss on cardiac glycosides, which are the drugs to increase the contractility of the heart. Then we will be moving to the heart failure. So, cardiac glycoside is basically combines a sugar moiety with the non-sugar moiety. The non-sugar moiety is called a glycon or genin, which is attached to the sugar moiety, that can be glucose, digitoxose and others. So basically only one drug, only one cardiac glycoside is presently clinically in use, that is Digoxin, where the three sugar moieties are attached to a steroidal molecule. Now, what does they cause? They increase the cardiac contractility. So they have got positive inotropic effect. How are they derived? They are derived from the plant sources, and they can also be derived from the toad skin, that is bufotoxin. Now, three basically cardiac glycosides are there: digoxin, digitoxin and ivabradine. Digoxin is obtained from the source Digitalis lanata, and it is the only cardiac glycoside clinically in use. Digitoxin, they are obtained from the plant Digitalis purpurea, while the ivabradine, they are obtained from the Strophanthus cretus. Now, coming to the history of the cardiac glycoside, it was first the scientist William Withering. He was a Birmingham physician. What does he did? He extracted the foxglove, that is digitalis, and they found to be remarkably effective in patients of dropsy, that means those having edema. And he ascribed the effect of this drug to the action on the kidney. But later, Kashni and Mackenzie, they established that this digitalis, it works on the heart and it is useful only in patients of congestive heart failure, not in any patient of edema. Now, pharmacological action of the digitalis, it has got primary action on the heart, action on the blood vessels, kidney and on the central nervous system. Now, coming to the action of the digitalis on the heart, the primary action, they have got positive inotropic effect, that is they increase the cardiac contractility, and they have got effect on the electrophysiological properties of the heart. Number two, they have got direct vagomimetic action. They increases the tone of vagus nerve. They have got reflex effect due to alteration in hemodynamics, and finally direct central nervous system effect affecting the sympathetic tone. Now, coming to the force of contraction, basically you see in the it's a basically graph. On the x-axis it is marked arterial impedance, and on the y-axis stroke volume. What we are seeing, as the arterial impedance is increasing in the normal heart, gradually the stroke volume decreased. In the heart failure patient with the same level of arterial impedance, the stroke volume is lower than that of the normal heart. And what does the digitalis is doing? They are increasing the stroke volume in a heart failure patient with the same level of arterial impedance or peripheral resistance. So they have got dose dependent increase in positive force of contraction. Number one, they more completely empty the failing heart, cardiac output is increased, and end diastolic volume, it is reduced. So coming to the effect on the heart rate, they decrease the heart rate. How? There are three actions. Number one, due to the positive inotropic action on the heart, as the cardiac contractility is increasing. So the peripheral perfusion is better, there is improved circulation, and that lead to the decrease in the vagal tone and reduction in the sympathetic overactivity. That leads to bradycardia. That is one effect. Number 2 effect is direct action on the vagus nerve. Direct vagomimetic action. They increase the vagal tone. And number 3, extravagal effect. They have got direct depressant action on the SA node and on the AV node. So these are 3 mechanisms by which it is decreasing the heart rate. Coming to electrophysiological properties. Now, this is the cardiac action potential. It's been shown of the Purkinje fibers. We all know that it has phase 0, phase 1, phase 2, phase 3 and phase 4. Now, what is seen due to the action of digitalis, resting membrane potential is progressively decreased. It is rising. Number 2, the rate of phase 0 depolarization are reduced. The slope you see in the digitalized heart is slightly lower. So, rate of phase 0 depolarization is reduced. What does it cause? It causes slowed conduction, particularly in the AV node and the bundle of His. So, digitalis, they are decreasing the AV node conduction. Slope of phase 4 repolarization is increased in the digitalized heart, particularly in the Purkinje fibers. So, what is happening? We all know that the primary pacemaker of the heart is SA node. Now, when the SA node fails, the basically pacemaker action is taken up by the AV node, and finally, if they fails, bundle of His, then Purkinje fibers. Now, what is happening? As the slope of phase 4 depolarization is increasing with the action of digitalis, the latent pacemaker activity of the Purkinje fibers may be increased, and that can lead to ectopic automaticity, leading to ventricular ectopics delayed after depolarization. So, slope of phase 4 depolarization is increased in Purkinje fibers, ectopic automaticity is enhanced, latent pacemakers become overt at high doses, producing extrasystoles. Resting membrane potentials shows oscillation during phase 4 when their magnitude is enough, delayed after depolarization occurs. SA node and AV node automaticity is reduced due to direct depressive action at therapeutic concentration, and the action potential duration is reduced in the digitalized heart, primarily in the phase 2, and amplitude of action potential is also diminished. Now, coming to the action on the effective refractory period, is decrease in the atrium and in the ventricle. In the atrium by vagal action and by the and increase by the direct action. Vagal action predominates, and in the ventricle it is decreased by direct action. In the AV node, the effective refractory period is increased, that leads to slowed AV conduction. Now, conduction, AV conduction demonstrably slowed by the therapeutic dose. At the high dose, intraventricular conduction in Purkinje fibers is also depressed. Now, coming to the ECG change. So, what can be the ECG change? We can see there can be increased PR interval. PR interval ki bojay. Physiology পড়েছো তো ECG টা? In the physiology you have read about ECG. So, what does the PR interval indicate? The P wave indicates atrial contraction, right? And the PR interval, that indicates AV conduction. As the AV conduction is slowed by the action of the digitalis, so there will be increased PR interval. So, what has been written? Increased PR interval due to slowing of the AV conduction. And AV block can be seen at toxic doses, high dose. Number 2, shortening of QT interval. QT interval mane? What does QT interval indicates? ventricular contraction plus relaxation, right? So basically due to the shortening of the APD, action potential duration, there is shortening of the QT interval, and we also see either depression or inversion of T wave and depression of ST segment at high dose. Now mechanism of action, how the digitalis or cardiac glycoside, that is increasing the myocardial contractility. They have got primary action on the sodium potassium ATPase pump, which are present on the cardiac, basically myocardial cells. So these are sodium potassium ATPase pump is the extracellular phase, is the intracellular phase. Now what does digoxin do? It binds to the extracellular phase of sodium potassium ATPase pump membrane, on the membrane of cardiac fibers. Now what happens? Sodium potassium ATPase pump, what does it do? They cause basically extracellular transport of sodium with the intracellular transport of the potassium. Now as the enzyme is inhibited, so there is increased intracellular sodium. Now intracellular sodium, basically they give feedback inhibition to the sodium calcium exchanger. As a result, calcium will be retained more intracellularly. So there is increased intracellular availability of calcium due to inhibition of sodium potassium ATPase pump. Now this calcium get stored in the sarcoplasmic reticulum. Now when the stimulus arises, more calcium is released due to the action of digitalis. There is more myocardial contractility. So it increases the force of contraction by direct action. Basically they bind to the extracellular phase of membrane associated sodium potassium ATPase of the myocardial fibers. They inhibit it. That leads finally to the intracellular calcium accumulation, which are taken up by the sarcoplasmic reticulum, which gets progressively loaded with more calcium so that subsequent calcium transients are augmented. Now binding of glycoside to the sodium potassium ATPase enzyme is slow and the calcium load occurs gradually. So the administration of cardiac glycoside and ensuing of the inotropic action get delayed. So it takes hours to develop even after intravenous administration. Now inhibition of sodium potassium ATPase clearly involved in the toxic actions of digitalis. Digitalis is a toxic effect dekha jay. This is because of sodium potassium ATPase pump only. At high doses, depletion of intracellular potassium ion results. Okay, so digitalis toxicity can be partially reversed by potassium infusion. Amra ki pollam sodium potassium ATPase pump inhibition er jonno there is more intracellular potassium depletion. When this intracellular potassium depletion is at the alarming level, so the toxicity is seen. That can be reversed partially by potassium infusion, because potassium decreases binding of glycoside to the sodium potassium ATPase pump. Now therapeutic index of digoxin is low. Why? Excess calcium loading of sarcoplasmic reticulum. They result in spontaneous release of the calcium during stimulus. When more calcium is there, more contractility, and basically these spontaneous cycles of release and uptake by the sarcoplasmic reticulum, they produce oscillatory delayed after depolarization. Amra ki porechilam phase 4 jeta slope ta ota bariye dicche. So basically that results in the ectopic pacemaker activity of the Purkinje fibers. Now more and more calcium, the delayed after depolarization is increased. Since both therapeutic and toxic effect of digoxin are due to myocardial calcium loading, so these drugs have got low therapeutic index. Now action of digoxin on the basically blood vessels. as the myocardial contractility is increased in patients of heart failure. So basically they basically key heart failure vasoconstriction hoy when the myocardial contraction is improved, peripheral perfusion is improved, there is vasodilatation, so heart rate is decreased. So they decrease in heart rate, no prominent effect on the blood pressure, they have got no significant effect on the coronary circulation. They promptly causes diuresis in congestive heart failure because they improve the contractility of the failing heart, peripheral perfusion is improved, there is improved circulation, blood circulation in the kidney, that causes diuresis and retained salt and water is gradually excreted. No diuresis occurs in normal individuals and in patients of edema due to other causes, not due to heart failure. Central nervous system, very little effect, generally in therapeutic dose, but higher doses they affect the chemoreceptor trigger zone, producing nausea and vomiting. Still higher dose can cause hyperpnea, central sympathetic stimulation, mental confusion, disorientation, and visual disturbance. Pharmacokinetics, bioavailability of digoxin of different preparations can differ. So a patient on digoxin of a particular brand should be kept on that brand, better. Presence of food in the stomach may delay absorption, so better to be taken in empty stomach. Volume of distribution large, concentrated more in the heart, blood vessels, skeletal muscles, liver and kidney. Half-life is prolonged in elderly and in those with renal insufficiency. Adverse effect, toxicity is high because of low margin of safety. Now, toxicity can be extracardiac, can be cardiac. Extracardiac, mainly gastrointestinal. It is nausea, vomiting, diarrhea, anorexia and abdominal pain are reported first. Diarrhea can also occur. Other than that, there can be fatigue, malaise, headache, mental confusion, restless, hypopnea and others. Skin rashes and gynecomastia are rare. Coming to the cardiac manifestations or adverse effect, any type of arrhythmia can occur with digoxin. Almost every type of arrhythmia can be produced, which is the most common. Pulsus bigeminus is the most common arrhythmia in patients on digoxin. Others are nodal and ventricular extrasystole, ventricular tachycardia, ventricular fibrillation. Partial to complete AV block may be the sole cardiac toxicity. In about 2/3 of patients showing toxicity, extracardiac symptom generally precede cardiac symptom. So, a patient on digoxin showing toxicity, the first to manifest in most of the patient is extracardiac, that is anorexia, nausea, vomiting, decreased appetite or maybe even diarrhea. Treatment of digoxin toxicity, if a patient having digoxin toxicity, generally the symptoms are mild. So, when a patient comes to you, we should stop the digoxin right away. That is the most important treatment. So, further dose must be stopped at the earliest sign of toxicity. Now, in patients showing cardiac toxicity due to chronic use of digoxin and diuretics, potassium infusion can be considered because diuretic cause hypokalemia and hypokalemia can increase the toxicity. But when a patient has acutely ingested large amount of digoxin, their potassium infusion should not be given because it can lead to more cardiac toxicity. In ventricular arrhythmias, lignocaine intravenously can be given. Supraventricular arrhythmias, propranolol intravenously or orally as may be required. In atrioventricular block and bradycardia, atropine can be of helpful and if required cardiac pacing. Cardioversion by DC shock contraindicated as that can cause severe conduction defects. Coming to digoxin antibody that has been marketed in Europe as Digibind or Digifab. it is highly effective in reversing cardiotoxicity of digitalis. They are non-immunogenic. Why? Because they have got FAB fragment and the FC fragment is absent, which is immunogenic. They are given by intravenous infusion. They improve survival in severe digoxin toxicity. Precautions and contraindications. Hypokalemia can enhance digoxin toxicity. Elderly, severe renal or severe hepatic disease can show digoxin toxicity. Thyrotoxicosis patient can develop digoxin arrhythmias. A patient of thyrotoxicosis are prone to arrhythmia. When they are put on digoxin, the chances of arrhythmia are further increased. While digoxin elimination is slowed in hypothyroid, so that can lead to digoxin toxicity. They are contraindicated in ventricular tachycardia, as that can be converted to ventricular fibrillation, that is more dangerous. Partial AV block may be converted to complete AV block. They are contraindicated in WPW syndrome. Interaction with diuretics. What does diuretic cause? It causes hypokalemia, and hypokalemia further increases toxicity, leading to digitalis arrhythmias. Calcium, more calcium, digitalis itself cause intracellular calcium increased in the myocardial cell. Now more calcium, more toxicity. Quinidine, they reduces binding of digoxin to the tissue proteins as well as decreases clearance, leading to toxicity. Verapamil, diltiazem, captopril, propafenone, amiodarone, they are increasing the plasma concentration of digoxin. Adrenergic drugs can increase arrhythmia. Adrenergic drugs can cause cardiac arrhythmia. With digoxin, the chances of arrhythmia is further increased. Absorption may be reduced by metoclopramide, sucralfate, antacid, neomycin, sulfasalazine. Can be increased by atropinic drugs including tricyclic antidepressants. Propranolol, verapamil, diltiazem, disopyramide, they additively suppress AV conduction and oppose positive inotropic action. Now, usage of digoxin. The digoxin has got role number 1 in heart failure and number 2 in arrhythmias, atrial fibrillation, atrial flutter, and in supraventricular tachycardia. So, coming to the arrhythmia, where the primarily drug is used, atrial fibrillation and atrial flutter. What is their role? They only control the ventricular rate. They do not cure the arrhythmia. So, they are used in controlling ventricular rate, whether associated with congestive heart failure or not, but incapable of curing arrhythmia. Often, in a patient of atrial flutter, when digoxin is given, the patient may show conversion from atrial flutter to atrial fibrillation, which is a welcome sign because it is basically more easier to control ventricular rate in atrial fibrillation than in atrial flutter. So often atrial flutter may be converted to atrial fibrillation. They reduces ventricular rate by decreasing number of impulses that are able to pass down through the AV node. We know digoxin, they are decreasing the conduction through AV node. So when in a patient of atrial fibrillation or atrial flutter, lesser impulse travels down the ventricle due to delayed conduction in AV node, and thus they are improving or they are rather decreasing the ventricular rate in a patient of atrial flutter and fibrillation. Now, may be used for long-term ventricular rate control in persistent or permanent AFL. So, atrial flutter, atrial fibrillation এটা continuous use করা যেতে পারে to control the ventricular rate, but they are not preferred drug for rapid control of heart rate. একটা patient acute onset very high ventricular rate নিয়ে এসেছে due to atrial fibrillation or atrial flutter. Now, digoxin কখনো কিন্তু rapid controlটা করবে না. So, what are the drugs preferred here? It can be beta blockers, it can be calcium channel blockers and others. Adenosine. Adenosine is the drug of choice in a patient of supraventricular tachycardia. They decreases ventricular rate in dose dependent manner Maintenance dose can be determined by titrating with heart rate. They can also be combined with beta blocker or calcium channel blockers if a single drug fails to lower the heart rate to the desired level. Paroxysmal supraventricular tachycardia. Now, it's a common arrhythmia with a rate of 150 to 200 per minute, having 1:1 atrioventricular conduction. It generally occurs due to the basically re-entry mechanism involving the AV node. Now, digoxin injected intravenously, they are increasing the vagal tone and depressing conduction of AV node, particularly on the ectopic focus. Thus, they are controlling the arrhythmia or terminating the arrhythmia. Adenosine, verapamil, esmolol, these are more effective, less toxic and act faster, and they are preferred. Coming to the heart failure, next topic. Heart failure basically is incapability of the heart to maintain the tissue perfusion. So, it occurs when cardiac output is insufficient to meet the demands of tissue perfusion, or is able to do so only at the expense of elevated filling pressure. It is a progressive disease with gradually deteriorating cardiac function or performance. Now, types, it can be systolic failure, it can be diastolic failure. What do we mean by systolic failure? Where the pumping action of heart is diminished. What do we mean by diastolic failure? Where the basically the filling pressure of the heart is increased. So, the heart has to maintain the cardiac output at the expense of more intraventricular tension. Now, recently the term systolic heart failure and diastolic heart failure, they have been withdrawn, and how we classify the heart failure patient: heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. This is notation for heart failure with reduced ejection fraction. What do we mean by it? Here the ejection fraction of the heart is reduced to less than 40%. Then the next term is heart failure with mildly reduced ejection fraction. In these patients, group of patients, the ejection fraction of the heart lies between 40 to 50%. And finally, heart failure with preserved ejection fraction, where the ejection fraction of the heart is more than 50%. There is another term called heart failure with improved ejection fraction. What do we mean by it? Hello? Heart failure with improved ejection fraction. सुना है? Hello? Heart failure with improved ejection fraction. Here the patient was initially having HFrEF, reduced ejection fraction. With treatment, the ejection fraction has improved and gone above 40%. They are called heart failure with improved ejection fraction. Now, systolic heart failure occurs due to deficient pumping action of the ventricles. The ventricles get progressively dilated, making the ventricle further inefficient. Ejection fraction is progressively reduced to less than 40%. Now, causes of systolic heart failure, it can be coronary artery disease, myocardial infarction, valvular cause can be there, dilated cardiomyopathy, myocarditis and others. Now, diastolic heart failure, here the ventricular wall is thickened and they are unable to relax normally during diastole. So, ventricular filling is impaired, stroke volume is reduced, but the ejection fraction may be normal. Long standing hypertension is the most important cause for it, for left ventricular hypertrophy and subsequent diastolic dysfunction. Causes: long standing hypertension, it can be due to aortic stenosis, it can be due to hypertrophic cardiomyopathy, AV shunts and congenital heart disease. Now, what are the compensatory mechanism in the heart failure? We have already all know from the physiology. Number one, elevation of filling pressure. Elevation of filling pressure leading to congestive symptoms. We all know in the heart failure patient, sympathetic activity is increased. That is leading to the beta receptor mediated cardiac stimulation. There is tachycardia, alpha receptor mediated vasoconstriction. So, peripheral resistance is increased, leading ultimately to the cardiac myocyte apoptosis and fibrotic change. These are called cardiac remodeling. Then activation of renin-angiotensin system. Now, due to the increased RAS, there is further vasoconstriction and left ventricular hypertrophy, myocardial remodeling finally result even due to activation of the RAS. Next, there is overproduction of aldosterone, that is also responsible for cardiac remodeling. There is endothelin increased production which reinforces vasoconstriction and cardiac remodeling. Release of ANP, atrial natriuretic peptide, and BNP, brain natriuretic peptide. They have got beneficial effect. What does they cause? They are released due to atrial and ventricular distension. They tend to oppose vasoconstriction and sodium retention. After initial hemodynamic benefit, these compensatory hemodynamic mechanisms in heart failure patient, they are trying to improve the cardiac output so that the patient get rid of symptom. So, after initial hemodynamic benefit, the compensatory ventricular hypertrophy becomes counterproductive. They lead to cardiac remodeling and increased mortality in patients of heart failure. It alters ventricular geometry, hampers ventricular filling, and predisposes to ischemia event. So, what are the goals of therapy in heart failure patient? Number one, symptom relief. So, relief of congestive and low output symptoms. And number two, arrest or delay the progression of cardiac remodeling so that there is survival benefit. Now, these are the drugs used in heart failure. Some drugs are useful to relieve symptoms. Some drugs are useful to basically arrest or revert the cardiac remodeling and showing mortality benefit. Number one is inotropic drugs. As the term denotes, it increases the contractility of the heart. The drugs are digoxin, already discussed. It can be dobutamine, dopamine, enamrenol, and milrinol. They basically provide symptom relief, but they have got no benefit in survival. Diuretics, they include furosemide. Furosemide is the most commonly drug, and that can thiazides are least commonly used. Metolazone can be used. They are basically responsible for symptom relief. No mortality benefit has been seen. RAS inhibitors, they include ACE inhibitors, ARBs. The recent addition is ARNI, that is angiotensin receptor neprilysin inhibitor, which basically involve a combination of neprilysin inhibitor sacubitril with Valsartan. So, they have got shown mortality benefit. Vasodilators, they include hydralazine, nitrates more commonly used, nitroprusside having symptom relief, synthetic BNP nesiritide, symptom relief, beta blockers, sustained release metoprolol, and bisoprolol, carvedilol, nebivolol, they are showing mortality benefit. MRAs, mineralocorticoid receptor antagonist, like spironolactone, eplerenone, they have got mortality benefit. The last addition of heart failure treatment is SGLT2 inhibitors, canagliflozin, dapagliflozin, empagliflozin, they are showing mortality benefit irrespective of diabetic status. Now, coming to diuretics, basically diuretics we know they cause diuresis. So, they are used in all cases of symptomatic heart failure. High ceiling diuretics like furosemide, these are the drug of choice. Later they may be continued in low doses. Resistance may develop on prolonged use of a diuretic. So in that case, either mineralocorticoid receptor antagonist can be added or metolazone can be added. Thiazides, they have got limited role. What does they cause? They decrease the preload on the heart by diuresis, number 1. And number 2, intravenously administered furosemide. They cause vasodilatation even before the diuresis is ensued. So they cause prompt relief in the heart failure symptom. So these are 2 mechanisms. Most mild cases do not require diuretics, but when the patient is symptomatic, diuretics can be added. In mild cases, ACE inhibitors ARB can be given to retard the disease progression, and diuretics can be given as and when required basis. No role in asymptomatic heart failure, do not influence the disease process, so no mortality benefit. May cause activation of RAS if basically diuretics are given, even if not required, that can lead to hypovolemia, increase in RAS activity that can deteriorate the heart failure patient. So may cause activation of RAS if hypovolemia occurs, which has got adverse cardiovascular consequence. Chronic diuretic therapy leads to hypokalemia, hypomagnesemia that can cause more prone to arrhythmias. Current opinion is to treat mild systolic heart failure with ACE or ARB or ARNI plus minus beta blockers only, and diuretics may be added intermittently for symptomatic relief. Chronic diuretic therapy should be reserved only in case of advanced cases. These are the primary drugs for heart failure with preserved ejection fraction. Dose to be titrated to the lowest so that patient is symptom free and there is no hypovolemia to cause activation of RAS. Coming to RAS inhibitors, they include ACE inhibitors, ARB and ARNI. These are the drug of choice or seat anchor of drug therapy in congestive heart failure. They afford symptomatic relief by vasodilatation, as well as they have got mortality benefit by retarding cardiac remodeling. In addition to, ACE inhibitors, they have got an upper hand over ARB in a patient of heart failure. Why? Because ACE inhibitors, they raise the level of kinins that cause generation of cardioprotective prostaglandins and nitric oxide. So RAS inhibitors, they have got symptomatic and prognostic benefit in a patient of heart failure with reduced ejection fraction, but they have got no role in heart failure with preserved ejection fraction. Recommended for all grades of congestive heart failure unless contraindicated or if renal failure deteriorates. ACE inhibitors or ARBs, they are started at a lowest possible dose, gradually up titrated as per the requirement till the maximum tolerable dose. Now, ARBs alternative to ACE inhibitors, but they differ in certain aspects. They more completely block AT1 receptor mediated effect. Unlike ACE inhibitors, they do not increase the level of kinins. So, cardioprotective prostaglandin function and the nitric oxide are not generated. Now, coming to cardiac glycoside, the only drug clinically in use are Digoxin. Not a first line drug for heart failure, but they can be used in conjunction with other drugs. They have got positive inotropic effect already discussed. They are incapable of reversing the cardiac remodeling, so they do not show any survival benefit. All patients with low ejection fraction who remain symptomatic, although receiving ACE or ARB or ARNI with beta blockers, should be treated with Digoxin. What are the major limitations with Digoxin therapy? Number one, low margin of safety. So even a small increase in dose of digoxin can show toxicity. Number two, they have got lack of effect on the neurohumoral contributors. So they are not showing any mortality benefit. Vasodilators, what we have got in our hand, number is vasodilators that include nitrates, glyceryl trinitrate, isosorbide dinitrate and isosorbide mononitrate. Number two is arterial dilators that include hydralazine, and finally both arterial and vasodilators that include nitroprusside. Now, direct acting vasodilators are primarily used in the treatment of heart failure or symptomatic relief. No mortality benefit is there. Utility of long-term oral vasodilator therapy in chronic heart failure is quite limited. Why? Because they are not showing any mortality benefit. They can be different. Basically, they are vasodilators. So they basically increase the venous cooling of the blood. They decrease the cardiac preload, and they are thus reducing ventricular end-diastolic pressure and volume. Now, monitored intravenous infusion can cause prompt rapid relief in patients of acute left ventricular failure. একটা patient left ventricular failure আসলে the two drugs we give for symptomatic relief are intravenous GTN, glyceryl trinitrate and intravenous furosemide. So they monitored IV infusion of glyceryl trinitrate, they afford rapid relief of acute left ventricular failure, particularly that due to the myocardial ischemia or infarction. They are indicated when central venous pressure is raised and in patients of dilated cardiomyopathy. Too much lowering of the preload may reduce the output of a failing heart, which is dependent upon the elevated filling pressure and can exacerbate the heart failure symptom. Number two problem is occurrence of the nitrate tolerance limit they use in routine treatment of congestive heart failure, and they are not showing any mortality benefit. Hydralazine, basically they cause arterial dilatation, they decrease the peripheral resistance or aortic impedance so that ventricle is able to pump more blood against the increased arterial impedance. They are effective in forward failure without any congestive symptoms. Marked tachycardia, worsening of the myocardial ischemia and fluid retention limit is used. Generally, hydralazine is not preferred. Now, coming to the sodium nitroprusside, they cause both veno and arterial dilatation. So, what is happening? They decrease in both preload and afterload on the heart. Cardiac output and the renal blood flow are increased. Action is very fast and brief. Now, survival benefit has been noted with a combination of hydralazine with isosorbide dinitrate. But definitely the advantage is inferior to that of ACE inhibitors or ARB. So the preferred drug is ACE or ARB. When a patient is there is contraindication to the ACE or ARB, then this combination hydralazine with isosorbide dinitrate can be preferred, particularly in patients of renal insufficiency, renal arterial stenosis, or in other cause where ACE or ARB is not given. Now, even African American patients with severe congestive heart failure who are already receiving ACE inhibitors or ARB with digoxin with diuretics have obtained extra survival benefit by addition of hydralazine with a nitrate. Coming to the beta blockers, we all know beta blocker, they decrease the cardiac contractility. So in the initial phase, when the drug is started, due to decrease in cardiac contractility, the heart failure may worsen. But in the long run, they are basically showing the survival benefit. So beta blockers should be cautiously used in a patient of heart failure. They should be started at a small dose, gradually up titrated as per the response, and the dose is gradually built up to the maximum tolerable dose. Benefit appears due to the antagonism of the ventricular wall stress, enhancing apoptosis, promoting and pathological remodeling. Incidence of sudden cardiac death as well as due to the worsening of heart failure is decreased. They lower plasma markers of activation of sympathetic, RAS and endothelin 1. Beta blocker therapy in heart failure, however, require caution, proper patient selection and observance of certain guidelines. Greatest utility is seen in patients of mild to moderate heart failure. It should not be used in patients of decompensated heart failure. So, it is used in NYHA class 2 and 3 cases of DCM with systolic dysfunction unless contraindicated. In one study, nebivolol has been found effective in both systolic as well as diastolic heart failure. Nebivolol, they have got added advantage of vasodilatation. Now, encouraging results have been obtained in class 4 as well, but it is risky and need constant monitoring. They have got no place in decompensated heart failure patient. The starting dose should be very low as the early negative inotropic action may precipitate heart failure. Dose is then titrated upward as tolerated to the target level or near to the maximum protection. In few patients, any attempt to add beta blocker increases the heart failure. In them, beta blocker should be avoided. Survival benefit has been demonstrated with sustained release metoprolol, not with the regular release of metoprolol, and which provide round the clock beta blockade but not with short acting metoprolol. So, in a heart failure patient, we never use short acting metoprolol. We always use sustained release metoprolol because that has shown survival benefit. No evidence of benefit in asymptomatic left ventricular dysfunction. Coming to aldosterone antagonists that include spironolactone and eplerenone. Rise in plasma aldosterone in heart failure we have seen that can have adverse cardiovascular consequence. Now, when we are using aldosterone antagonists, although they are weak diuretic, but they are antagonizing the effect of the aldosterone and thus they are retarding or basically arresting the progression of cardiac remodeling, and thus they are showing survival benefit. Aldosterone antagonist spironolactone is a weak diuretic but can benefit congestive heart failure by antagonizing the above effect of aldosterone. Gynecomastia can be seen with the use of spironolactone, where it can be avoided by using eplerenone, which have got lower gynecomastia adverse effect. Now, current recommendation for aldosterone antagonist used as an add-on therapy with the ACE inhibitor and other drugs in moderate to severe heart failure with reduced ejection fraction. Role in HFrEF is uncertain. Retard disease progression, reduce hospitalization and death due to heart failure and sudden cardiac death. Only low dose should be used to avoid hyperkalemia and help restoration of diuretic response to furosemide when refractoriness has developed. We have seen that continued use of a diuretic, high serum diuretic, can cause refractoriness. The diuretic response decreases. Now, in those cases, addition of a MRA can decrease the refractoriness of a diuretic. SGLT2 inhibitors, initially the drug was introduced to treat diabetes mellitus, but later on it has been seen that they are helpful even in patients of heart failure and chronic kidney disease even. So, SGLT2 inhibitors are the latest addition to the guideline directed medical therapy in heart failure with reduced ejection fraction. Recent trials have also shown that they are effective in HFmrEF and HFpEF. Drugs currently approved are dapagliflozin and empagliflozin. ADA recommend SGLT2 inhibitors in type 2 diabetes with heart failure or at high risk of heart failure. Again, different heart failure society, they recommend use of dapagliflozin and empagliflozin in the management of chronic stable heart failure with reduced ejection fraction, irrespective of the diabetic status. And nowadays they are also recommending in the patients of heart failure with MRAs and heart failure with preserved ejection fraction. Sacubitril and Valsartan combination, ARNI. Sacubitril is an orally active neprilysin inhibitor. What does they cause? They decrease the degradation of the ANP and BNP, and thus they are promoting vasodilator effect and diuresis. Thus they are effective. Combined with Valsartan, they provide symptomatic relief as well as they have mortality benefit. They are used in advanced heart failure to decrease the incidence of death and acute decompensation. The drug has been approved for heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. A greater reduction in hospitalization and mortality compared to enalapril has been reported. Ivabradine. What does Ivabradine do? Ivabradine decreases the heart rate. They have got direct action on the SA node. They decreases the heart rate only in patients with sinus rhythm. Now, they are approved recently in a patient of heart failure with NYHA 2 to 4 who are in sinus rhythm, not in any arrhythmia, having heart rate more than 70 and with systolic dysfunction, EF less than 35%. In which patient, which group of patient? Where beta blocker is contraindicated or the target of heart rate is not achieved even with the maximal dose of the beta blocker. They have been shown to decrease composite endpoint hospitalization and CV mortality. However, they lack the cardioprotective properties of the beta blockers. So, definitely beta blockers are more preferred. Sympathomimetic inotropic drugs, dopamine and dobutamine. What does they cause? They increase the contractility of the heart and they are particularly useful in patients of heart failure with hypotension. No role in long-term management. They are not showing any mortality benefit. Phosphodiesterase 3 inhibitors, predominantly present in the heart, in the blood vessels. Now, they are also called inodilators. Why inodilators? They are increasing the contractility of the heart and again they are causing vasodilatation. So, inodilator include enamrinol and milrinol. They are selective PDE3 inhibitor. Milrinol is more selective. What does they cause? They inhibit the intracellular degradation of cyclic AMP in the heart, blood vessels and bronchial smooth muscle, and thus they are causing positive inotropy. Thrombocytopenia is a major side effect, more seen with amrinol than with milrinol. Other side effects are nausea, diarrhea, abdominal pain, liver damage. In amrinol is seldom used for thrombocytopenia. They are used for short-term therapy intravenously in a patient of acutely decompensated heart failure when other standard therapy fails. Levosimendan, they are another inodilator. They have got action on the PDE3 and they sensitize the myocardial troponins to calcium. Now, they are infused intravenously, used for the short-term therapy in the acutely decompensated heart failure, no improvement in mortality. Nesiritide is a recombinant BNP, continuous IV infusion, it enhances salt and water excretion and is a potent vasodilator, no long-term benefit. Tolvaptan is a vasopressin V2 receptor antagonist. V2 receptor, we know the primary action is antidiuresis. Now, as they are antagonists, they are causing diuresis. They cause free water clearance. So, they are used for short-term improvement in congestive heart failure patient with hyponatremia. No long-term benefit. Now, these are the treatment guidelines for the heart failure patient, latest. The guideline directed medical therapy for HFrEF include 4 drugs. Number 1 is ACE, ARB or ARNI. Number 2 is mineralocorticoid receptor antagonist, 3 beta blockers and SGLT2 inhibitors. These 4 drugs should be given in patients of HFrEF because all of them are showing mortality benefit. SGLT2 inhibitors are also recommended in HFmrEF with weaker recommendation for drugs of other 3 class. So HFmrEF patients, the drug of choice is SGLT2 inhibitors. The others have got weaker effect. Newer recommendation for HFpEF include SGLT2 inhibitors, MRAs and ARNI, not ACE or ARB. Patients of HF improved heart ejection fraction should continue their treatment with treatment of HFrEF. Diuretics are recommended in patients of heart failure with fluid retention to relieve congestion, improve symptoms. Addition of thiazide to loop diuretics should be reserved in patients of heart failure to decrease the refractoriness and improve the effect.